Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to talk about ultrasound in cardiac arrest. I don't know how I haven't hit this one yet, and I wanted to bring on a true expert, so I got the host of the Ultrasound Gel podcast, an amazing ultrasound podcast, Mike Prats, to come on and speak about his new concept about the ultrasound hierarchy of needs in cardiac arrest. Now, before we get to that, super quick, Flameproof, our anti-burnout course for emergency medicine and critical care, is starting next week, next Tuesday to be precise. And it might be the last live version of this we do ever. And we could still fit you in, but after it starts, that's it. This might be the last iteration of this course in its current format. So if you are feeling burnt out or you want to stave burnout from ever happening in your career, come to flameproofcourse.com. That's one word, flameproofcourse.com, and check it out, because I think it could really make a difference, because the first few cohorts we had, it's been amazing, the changes we've seen wrought in the levels of flourishing of our participants. All right, let's roll right into the show. Who are you and what do you do?
My name's Mike Prats. I'm an emergency physician in Columbus, Ohio. I'm the director of research in our division of emergency ultrasound, and I run the Ultrasound Gel podcast, where we review literature in point-of-care ultrasound.
I love the Ultrasound Gel podcast, and if people aren't listening, then they should, if they have any care about ultrasound. And you can't be an EM without a care about ultrasound. You should be retiring if you're still one of those people like, I don't buy ultrasound. So you came to me with an email. You're like, Scott, I got this new idea of how to really contextualize ultrasound during cardiac arrest. So what brought this about, Mike?
I love to teach ultrasound, and cardiac arrest is such a rich area for research and learning about it, and actually a clinical impact for point-of-care ultrasound. There's lots of different ways that have been described that it's beneficial in cardiac arrest, but I felt like there's sometimes almost too many where it's hard for people to wrap their heads around how to use it clinically and what's important, what are your priorities. So I came up with this hierarchy as a way for myself to organize it in my head. And it's mostly for teaching, I think, to have a framework for how I want the learners to prioritize ultrasound in this situation. Not so much like a chronological, like you need to do ultrasound in this order, but more like how we want to focus our training in cardiac arrest ultrasound.
Perfect. And you tailored it similar to Maslow's hierarchy of needs, where there's a triangle and you go up, and the idea is without the building block of the former foundation, you can't go to the next level. So what starts us off, Mike?
So at the bottom of the pyramid, the broadest part is do no harm. And I think that's super important, because there's a lot of ways that ultrasound can cause problems in cardiac arrest.
For sure. And with the most obvious one, and the one that annoys me most, is when actual things we know save lives, like continuous compressions, get knocked to the side in order to just get these ultrasound views. How do you think about this, and how do you avoid that?
Yeah, there's been a lot of papers, at least a couple of papers, that have shown that when you use ultrasound in cardiac arrest, it does lead to more time not doing the compressions that we know are so important. And so there's a couple of tips that you can do that will help mitigate that possibility, because I don't think it's unavoidable. I think if you do a good job, you don't have to take more time off the chest. So I would say there's a lot of things that have been published that are very valuable that you should incorporate if you're doing ultrasound in cardiac arrest. Pre-pause imaging is a quick one. That just means getting the image before the compression stops, so you know what to expect when they stop. Sometimes you can even get a pretty good image during compressions that way, and then you have your image automatically. You don't have to waste time trying to find that. You can adjust your clip time or otherwise have a timer. So I like to set the clip time on the ultrasound machine to 6 seconds or 4 seconds, something with a little margin there, so that when that clip ends, you hear that little beep. That's a signal like you got to get out of the way, let someone start the compressions again. Or alternately, you could just have a person in the room who's doing the timing for you, and just say, hey, that's enough time on the ultrasound. Other people have said not interpreting it in real time can be valuable. It depends how fast you can interpret the ultrasound once you get it. But you could always just save that clip, get out of the way, and then interpret it while they're resuming chest compressions. A big one, too, is to know who's doing the ultrasound. It shouldn't be the least trained person. It should be actually someone that's very facile and can get those images easily, so that, again, takes less time to get the quality images. And then the last thing I'll just say is maybe having a protocol or at least some methodical way that you're thinking through what you're looking for can be helpful. And TEE, if you have TEE, that also can save some time.
No doubt. We're going to restrain our conversation today to just TTE because I think that's what the majority of the providers have. Now, I have seen papers where they're like doing ultrasound every single rhythm check, and that is baffling. For me, it's like I want one piece of information in terms of ruling out avoidable causes and maybe knowing what's going on with that heart activity. And we'll talk about that as we get higher up in the triangle. But it's certainly not every rhythm check. That is going to be an incredible impediment to continuous CPR. What is your stance on this, Mike?
I totally agree. I think that's the other way you can go awry here is thinking, oh, I love ultrasound. It's helpful. I'm going to do it every single rhythm check. And that's unnecessary for the vast majority of cases. Every single time you use ultrasound, you should be trying to answer some extra question that you have. The vast majority of our cases, oftentimes not much has changed from 5 minutes ago when you go to check it again. Really have something that spurs you to doing that ultrasound every time will help you from doing unnecessary scans.
Are you predominantly doing parasternal, subxiphoid, or a combination based on body habitus? What is your stance?
I usually start with subxiphoid just because you do get a pretty reliable window there through the liver, but obviously there's challenges to that view with chest compressions ongoing. Sometimes that means the abdomen's like pumping in and out, and that can be difficult depending on the body habitus. Depending on if you have a person doing the compressions or if you have an automatic device, sometimes you can sneak your probe and get a parasternal view up there, which I find pretty valuable. And then apical, a lot of people think it's hard to get in an arrest, but it's definitely an option. So I guess I didn't really give you a straight answer, but I think I take whatever I can get and whatever gives you the best view.
No, that's a perfect answer. So you start off with subxiphoid, but then you'll work around with whatever gives you the best shots. I love it. What's the next level on that triangle?
The next level is diagnostic. And I put this as the next level up because there's probably the most evidence for this. And it also is just a continuation of how we use transthoracic point of care echo in the emergent setting anyway. So it's just looking for those things that could have caused the arrest. Is there a huge effusion? Do you suspect that this right heart strain is from a pulmonary embolism? Sometimes you can pick up fine V-fib, signs of hypovolemia or hemorrhagic shock, and then maybe even pseudo-PEA, which I think we'll get into more later.
Yeah, the pericardial tamponade is going to be, I think, the biggest win because you're never going to suspect that without echo. I mean, you could have a history that's suggestive, but this is like a game changer. It changes the entire face of the arrest. PE is a tougher one, and you alluded to this in the data you sent me, but I found every right heart gets distended in the course of CPR, and papers support that, and I think that's your view as well. So how are you really using RV distension to really discern, is this the PE patient versus this is just the patient who's had ongoing CPR?
That is a challenge, but I have my own personal approach that is not 100% evidence-based. But I think we do know, based on largely some pig studies, that everybody's RV will dilate regardless of the type of arrest, or at least for some common arrhythmogenic arrests. The way that I think of it is it does still take a little bit of time to dilate the heart from the arrest itself. If I have an arrest with a pretty minimal time since they've been arresting and I see a huge RV, then I'm more likely to trust that could be an acute cause of the arrest. If this is someone that has been worked on for 40 minutes before they even get to me and then they have a large RV, I am less likely to act on that. And of course, you can take into account all the other factors, such as if you know anything about their risk factors, or if they have a giant swollen leg in front of them, then you might be more suspicious for PE.
All right, so we've had two levels of the hierarchy so far. We've had do no harm, and then we've had using it for diagnostic purposes. Are you using any particular protocol for your diagnostic assessment?
There's a lot of great studies that have been published on this, such as CASA is a popular one, but there's a number of different options that walk you through methodically. Like first, I'm going to look for pericardial effusion, then I'm going to look for signs of right heart strain. And I don't necessarily stick to one. I just have those big ideas of what this could be in my head, and I just save a clip and I look for them all at once, ideally, or at least quickly, consecutively. So I don't follow a particular algorithm. I think it can, again, be tailored to the patient in front of you and what you think's actually going on. And we talked so far about looking at the heart, but remember that once you get further into the arrest, of course, you could consider ultrasounding some other parts as maybe relevant. And one of the most commonly relevant would be their lungs in case your compressions give them a pneumothorax. I often will just throw on the probe there and make sure there's not a huge pneumothorax, because that, again, is an actionable thing that you could do where you might need to decompress that side.
Now, I found looking for lung sliding during compressions to be an enormous pain in the ass. There are some more advanced ultrasound techniques. What are you using to discern pneumothorax during a cardiac arrest?
Yeah, lung sliding is definitely the go-to because I'm really looking for a huge pneumothorax, something that I think is hemodynamically affecting the patient. But you can also, a lot of these patients, after having compressions for a while, will develop some extent of pulmonary edema. And if you have B lines, that also will rule out pneumothorax in that area. So anything from lung pulse, lung sliding, B lines, if you see anything like that, then in my mind, if I see that in one spot, at least they don't have a humongous pneumothorax.
And you're good enough to do that during compressions, or you're just waiting for the pulse check?
Yeah, I would do that during compressions. If you get a good enough view of the pleura, I feel like you can see it with reasonable accuracy. And I will say that one big thing, one easy troubleshooting if you're having trouble seeing lung sliding is just turn the gain way down, like way, way down, almost all the way down. And because the pleural line will be the last thing that you lose as you turn down the gain. And sometimes that alone helps you see that little bit of sliding.
That's a great tip. Now, what I would not recommend, and I'm curious to see if you agree, I imagine you will, is people have thought that this seashore sign and actually doing that with M mode, which we sometimes do for documentation purposes, is a great way to do the diagnosis. And I have found that to be grossly inaccurate compared to actually looking for the lung sliding. What's your stance on that?
Yeah, for a lot of applications where we traditionally taught M mode, I'm actually not a big fan of those. Mainly, I believe if you can see it with your eye, then why do we need to add another element of confusion to it? And I understand there's actually been a great study that was, I think, done by my friend Jalen Avila and Ben Smith that looked at if you use M mode, does it increase the accuracy of identifying lung sliding? And the gist of that paper was that if you're an expert, it doesn't increase your accuracy too much, but maybe when you're early on in the process learning it and you haven't seen a lot of lung sliding, maybe then it can have a benefit. But I just teach people to look at that lung sliding, and really, if you can see it, that's just the best way to go, because there's so many ways that the M mode can deceive you, especially if you're trying to do it during compressions where everything's going to be moving back and forth on the chest. That's going to be a disaster.
All right. Is there anything else on diagnosis before we move up to the next tier?
I think that's pretty much it. Like you said, if we were to diagnose a pericardial effusion and we suspect that this could be tamponade, then there is some data, especially from the Reason trial, which a lot of this cardiac arrest data comes from, that showed the survival then really skyrockets. Like in that study, it went from 1.3% up to like 15%. So I think if you find an actionable cause that you can treat, that really is going to help out the patient.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Yeah, and the one we had to mention I just put out there is if I see an empty heart, that also changes radically, because most of the time we're dealing with these cardiac arrests, we're like, this is a medical cause. But if all of a sudden that is just a completely underfilled heart, then is it hypovolemia or bleeding? I start actually going through those mental heuristics of what the hell is going on here. This is weird, because they should have a distended heart in the course of cardiac arrest.
Definitely.
All right, then we move up to the next tier, which is
prognostic. So now we're talking about that case where you put on the ultrasound probe in a cardiac arrest and you're trying to decide, do I want to keep going with this arrest, or do I think that not having any cardiac activity is good enough for me to say the chance that they're going to have a meaningful survival. There's been a good amount of data on this too. And the Reason trial that I mentioned just a minute ago was really what put this on the map. It was a great prospectively done multi-center study of cardiac arrest in both the ED and out of hospital arrest. And basically what it found was that the presence of this cardiac activity was one of the most powerful indicators whether that patient would get ROSC and survive to hospital admission. It works the other way too, where I feel like it's more common that people try to say there's no activity, I'm going to call the arrest. And that is helpful, I think, in a lot of situations. But keep in mind that even in that study, some of the patients that had no cardiac activity at one point ultimately developed cardiac activity, and some that had no cardiac activity did actually survive to discharge from the hospital.
Yeah, I think that's a perfect contextualization. And it's the same thing with end-tidal CO2. No, you can't just say dichotomously, oh, nope, they don't have heart motion, done. What you have to do is say, oh, I already don't like what's going on with this arrest. And then they don't have that. That has a Bayesian effect that should bring you to a threshold or not based on your patient's individual characteristics. So yeah, it's just one more thing of this is not going well when there's no heart motion, but it doesn't mean they have zero chance of survival. All right.
Exactly. I would love to say one more thing about using it for the prognostics, because there's an important teaching point. It comes up a lot. What qualifies as a good motion of the heart to count? And I tend to use the definitions that was put forth in some of these Reason papers, where there's coordinated movement of the myocardium, not counting stuff that happens with the valves or little twitches here and there that may even be as a result of bagging, but coordinated contracting of the myocardium enough to change the size of the left ventricle. I think that's enough to call it. And we know that it's really important to define this because there's been studies that show there's a lot of variability in interpretation, where someone would say, yes, that person's alive. Some would say that person's dead. And that gets a little dicey. So I want to make sure that everyone has an agreed upon definition. And we're just looking for something that should be enough to generate blood flow to their brain and heart so that then theoretically they could get ROSC.
I love it. All right, so we're done with prognosis. Now, the next one I would say maybe is too high up because I would like to see everyone doing this with ultrasound. I'd like them to look for pericardial tamponade. And then the next thing I'd like them to start doing during arrest with their ultrasound is pulse check. So why is the pulse check up so high, Mike?
I went back and forth on this too when I was thinking about this. I agree that pulse checks could debatably be on the other side of prognostic, but the reason I put it up a little bit higher is because it's a little bit newer, I think, than some of the prognostic uses of ultrasound in cardiac arrest. So it does take a little more nuance, but otherwise I agree that in terms of importance, could be arguably lower on the pyramid. And what we're talking about here is instead of using your old-fashioned fingers for a manual pulse check, you might use the ultrasound to check for a pulse when that's appropriate. And that could be anything from looking at the heart, looking at the carotid, looking at the femoral artery. There's a lot of different ways you could do it.
How do you do it?
What I started to do recently is look at the carotid arteries, because I saw this one paper that made a lot of sense to me, where you put your linear probe on the carotid artery and you're compressing it enough that you start to see collapse of the vein, which can sometimes be dilated. And if you're pushing it down, sometimes while it's compressed, you'll start to see that pulsatility a little more obviously. And I think the carotid is a little bit of a safer way to say that there's good blood flow than the femorals, where anything could be happening between the heart and the legs. So I think that for me, finding that there's good blood flow to the brain is important. And so I tend to go for the carotids, which are usually superficial and easy to get in the majority of people.
Yeah, it's interesting. I've done some discussion on this on the podcast. And when you actually could palpate a pulse, that implies a greater blood pressure than you're going to see when you could find an ultrasound pulse. And for me, ultrasound pulse is the first step, and it makes complete sense because if they don't have that, they definitely don't have a perfusing pulse to their extremities or legs that you'll be able to feel. So then I'd go a step further and actually assess how much blood flow or its surrogate blood pressure that's generating. Now, carotid makes a lot of sense. I'm okay with femoral too, but like I said, it doesn't really imply perfusion, but there have been ultrasound studies that actually look at using Doppler to not just get an assessment of ultrasound pulse, but really have an idea that there is good blood perfusion to the body. And I'm sure you're familiar with, you probably know better than me, the recent one that came out looking at femoral Dopplers for this, and then it was correlated with a reasonable map. What do you think about that for people that are a little bit better at ultrasound?
Yeah, I think if you can do that very quickly in an arrest, then that can be valuable information. And again, it comes down to how many people do you have helping you out? Because if you're the one running the arrest, you're like at a one doc shop, that's a tall order to trying to do complicated Doppler things while you're also shouting out, trying to think through what's going on. But if let's assume we have 50 people at this arrest and all your jobs can be delegated except for doing the ultrasound. In that case, I think you can get valuable information from the Doppler signal. Although I feel for the vast majority of cases, you may not need to do that. You can get what you need from just, is there a pulse or not?
100% agree. You wouldn't be doing Doppler at all until you actually finally, during the arrest, see you have a femoral ultrasound pulse. And then while they're scrambling for the blood pressure cuff to discern whether or not that's adequate to continuously stop compressions, that's when I would throw the Doppler on and see what am I actually generating in terms of forward flow here. Now, you could argue, okay, end-tidal CO2 is probably going to give you that same amount of information, and oftentimes it will. But I think what's clear is ultrasound pulse beats finger pulse. You've put a couple studies, there's more out there. Trying to figure this out with palpation is just garbage, and you'll miss it in both directions. And so I think this should just become standard of care, at least until the companies decide to profit on this and create something that will just sit on the vessels and not have you actually have to do it, which is soon to come.
So what you're referring to is like the sonographic A-line, where after you get ROSC, then you're now trying to say, is there a good waveform? Do I have enough to say, let's start treating this post-arrest care and stopping the arrest care?
Precisely. Exactly right. All right. Anything else we should mention on pulse checks?
I don't think so, but I think they can be helpful. So if you're not doing them, maybe start.
All right. Last on the pyramid is tailoring resuscitation. Tell me about this.
I put this at the top of the pyramid because it is extremely important, but it's also a higher level skill, I think, to be able to understand what you're seeing on the ultrasound and know what to do as a result. So there's two main things that you can modify your resuscitation using ultrasound in a cardiac arrest. And the one would be to identify what some people have called pseudo PEA. And the other one is just moving the vector of your compressions to a better place in the heart. And that was popularized by TEE, but it can definitely be done in select patients with transthoracic echo as well.
So why don't you start off with what you mean by prem and press in your outline here, and tell me what that means to you and how you use ultrasound to assess it.
If I'm not mistaken, I think it was you that invented prem and press, or at least came up with those names. But what we're talking about is a patient in PEA. They're not all homogeneous. There's a spectrum of cardiac activity that may be present. And what we're saying is that if you have PEA, where you have some sort of electrical activity of the heart, in some instances, you will actually have function of the heart. It's probably not going to be good function of the heart because remember, they're technically pulseless. But in some cases, you can do your ultrasound of the heart that it's actually beating. It looks coordinated. It fits our definition of this person has cardiac activity. And what you can do in that situation is instead of giving them the monster boluses of epi, as we are wont to do in cardiac arrest, you could instead tailor it to doing maybe a more beneficial drip of your vasopressor of choice, like epi or norepi. And that can sometimes be helpful. And there is some evidence, again, using that reason data, they analyzed it and they found that in patients that have that cardiac activity in PEA, when you deviate from standard ACLS and you use a vasopressor drip, those patients will have a better survival to ROSC.
Okay, absolutely. I couldn't agree more, obviously. You're taking the words right out of my mouth. And now, the change in hand positioning due to the inadequacy of left ventricular compression is an interesting one because Felipe Turan did a bunch of the work for the TEE data, and he would argue quite aggressively that the plane we're actually looking at with TTE is inadequate to assess true LV compression because we're looking at essentially a coronal plane with most of our views. And what you want to see is a sagittal plane of the compression from the patient's sternum down to their spine. And he would say that for most of the views, though I think there are some modified views you could do to ostensibly get the same view, it's not really measuring. Even though you see nicely the LV compressed, it's not the compression that actually is telling you whether or not it's adequate. So are you using modified planes for this, or do you disagree with Felipe and feel you could use standard subxiphoid views, for instance, and get the information you need?
I would never disagree with Felipe. I agree that let's first say that TEE is going to be 1,000 times easier to do this than TTE, but it is possible. And since a lot of places don't have TEE, then what I would say is you can, in some cases, get this view. And the way that I think it's possible is the apical 3-chamber view. So you can see the LV as well as the left ventricular outflow tract. You can then see pretty much the plane of compressions that you are interested in. And as I alluded to before, sometimes too, you can sneak your probe into a parasternal window besides the compressions. And from there, being directly on top of it, you can at least see where the heart is in the chest and figure out, are these compressions happening at approximately the right location? Because what we're trying to differentiate here is the compressions on the ventricle, which is good, pumping blood, or is the compression on the aorta, which is bad because it's actually impeding the outflow of blood. And there's a paucity of literature of doing this with transthoracic echo, but it seems feasible anecdotally. I've seen it happen. I think it makes sense that if you don't have TEE, that's something to consider.
Absolutely. Now, you sent me a paper on this that I hadn't seen. It was great. They were using transthoracic, and they seemingly were able to ultrasound reposition hands and confirm that it actually benefited the patient's perfusion by correlating it with increases in end-tidal CO2. Now, I tried to parse what they were actually doing, and I found it very confusing, what views they were getting. Some of it was like, yeah, we were assessing, but the compressions weren't being done at the time. And then I'm like, then how are you assessing compression adequacy? It was a weird kind of methodology section, but it does give some limited support to this idea that maybe you can discern with TTE something valuable. What was your take on that paper, Mike?
Yeah, it wasn't the highest quality of evidence. To me, it was like, okay, I already thought it was possible, and some other people now think it's possible. So I would not put too much into it, but I think it, again, in the absence of it's going to cause any problems, if you're able to get that view, then I think it can, in select cases, be beneficial.
All right. Now, is there anything in cardiac arrest that is not on the hierarchy yet? Things that might be coming down the pike, things that you're doing, but you're like, oh, this is just too complicated for me to recommend on a podcast. EMCrit's different, man. You can recommend any crazy shit here. So what's coming down the pike, and what are you doing that's not on this hierarchy?
I think, first of all, procedures we didn't talk about at all, but obviously ultrasound can help you for any sort of procedure you want to do in a cardiac arrest. And for example, if you're putting in a chest tube, checking where the diaphragm is, making sure you're going in the right spot. Some of these things are basic. Obviously, if you're going to do a pericardios, ultrasound can help you. And even airway stuff, there's a million ways ultrasound can help you with procedures. So we'll take that off the table. I think the most interesting things coming down the pike in critical care ultrasound and cardiac arrest possibly would be transdermal ultrasounds, where you have patches that can do ultrasound and then through non-invasive ways try to give you surrogate cardiac outputs. And that can be really helpful. You can imagine how there's not that much data on this yet, but you could at least use your imagination in hopes that what you could someday get is you put this patch on the patient's carotid or something, and eventually you get a little waveform or cardiac output that's just a continuous monitor of what's going on with their blood, and that can somehow help you know when they have ROSC.
Very cool, man. All right. I love the hierarchy of POCUS needs during cardiac arrest. And how could people find you, Mike?
You can always email me. I have an email at mike@ultrasoundgel.org. I'm on Twitter at PratsEM. And I would also just say this is still in draft form. So if you have thoughts or feedback, I'm really interested because I want to make sure I'm teaching this in a good way.
Fantastic. And deriving from your email address, if they want to follow the podcast, it's ultrasoundgel.org. Is that correct?
That's right on.
All right, man. Thank you so much for coming on the show.
All right. Thanks for having me, Scott. A lot of fun.